if they all don't catch a case of the dropsies, I don't know if the 49ers have the offense to keep up.
We'll see if somebody can cover Kelsey. I
That's what I
think
mean. Like, oh,
that'll
well,
be the
Kurt Warner might be able to,
X factor of the
but if
game, I
Kurt
think.
Warner's covering Kelsey, they're not covering CMC. Or
Yeah.
yeah, if they're not covering Kelsey, I mean they're not covering Pacheco.
Yeah, I agree. Pacheco
Yeah.
could be an X factor as well. Hey, everybody that's joining in early, appreciate you being here today. I see some repeat attendees, and those of you that are new, appreciate you joining in. We're going to get started here in just another minute. We're going to wait to see if a few other people join. For those that are joining new, appreciate you guys joining in, and we're going to start this session with a quick trivia question, and just to get the blood juices flowing. I know for some it's around lunchtime or maybe just getting done with lunch. So
It's nap time now.
If you guys are joining in now, who do you guys got in the Super Bowl? Leave a comment. We got the Chiefs or the 49ers. You know, it's funny, Dr. Headley, he just got back from Vegas and
I lost the jersey. Can't see it.
where'd it go? No, it's camera. There you go.
Yeah, there you go. Wow. I'm
Dr.
not surprised that Vegas has all the merchandising out already.
Dr. Headley, he was in Vegas. He brought it back, and you know what? I appreciate that. I'm gonna wear it to the Super Bowl party this weekend.
Way to hedge your bet, right?
Yeah. All right, Tisha. Tisha's got the 49ers. Awesome. Tisha, I hope the 49ers win. That's who I'm going with.
Uh,
But it's gonna be tough. I don't know. We'll see. We'll see.
well, I mean, I'm okay with it because then I can tell my Cowboys friend that hey, 3 of the NFC West teams have gotten a Super Bowl since the last time you got one.
That's true. All right, we'll go ahead and
And
get it going. So let me go ahead and share screen. Jose, let me know if you can see. And we'll start off with
there
our
we go.
weekly trivia question. So again, for those of you that are repeat, you know, I like to keep this interesting. Today's one is a good one. Which organization founded the Certified HIPAA Security Officer Training Program? Is it A, CMS, B, EPI Conferences, C, HHS, or D, DEA? You guys can put your answers in the chat. We'll give it about a minute. Why is this menu bar over here today? Let me move that over. Come on, don't be shy. Evelyn says C. Health and Human Services Department. Interesting. Darlene says C. Get 10 more seconds. Victor says A. So the answer is actually B, EPI Conferences. And for those for those that are joining new, probably didn't expect you to get this one, but again, we've been conducting these webinars since September of last year, and we make it a point to talk about our Certified HIPAA Security Officer Training Program. We actually, EPI Compliance founded EPI Conferences, which is an in-person conference event where we host this training. And Jose, I didn't know if you want to elaborate a little more on this training and the specifics behind it.
Yeah, it's an 8-hour boot camp. We've been doing these CHSO certification since 2015. So we were in partnership with the consulting firm that my family runs. We've been running the entire certification process since then. It basically encompasses an 8-hour boot camp with a test that you've got to pass, and then there's actually a timetable for how long that certification is good for. So it's something that we saw coming down the pipeline from when actually MACRA came out, and there were certain details and requirements that that the federal government was looking for out of security officers. It wasn't just to say, hey, I'm the security officer because everyone comes to me for every question in the office. No, now there's responsibilities, there's penalties for doing things incorrectly. Like there's actual teeth on there now. So it's got a little bit more depth to it.
And this is a course, as we had previously mentioned. We currently offer it at our in-person events, but it is a course that we're going to be offering here online very soon. Hopefully by the end of the first quarter. But stay tuned. I'm going to be sending out information on that as well. And like I said, we recommend anybody that is looking for a deeper dive into HIPAA, whether you're a healthcare professional, a business owner, an admin, et cetera, compliance officer, highly recommend taking a look at this course. It is very extensive, very comprehensive. And like I said, it'll give you a very deeper understanding of HIPAA and what that entails. But anyways, without further ado, let's get it going with today's topic. We're going to be discussing the core elements of MACRA and MIPS, and let's go ahead and get it going. And
Yeah,
again,
so go ahead. I'm sorry.
yeah, no worries. Again, for those that are tuning in, appreciate you guys being here. And again, those that have been here to several of our webinars, appreciate you coming back. Again, today's topic, we're going to be discussing the core elements of MACRA and MIPS. My name is Ray Walters. I'm going to be your host for today's webinar, and thrilled to have my colleague and distinguished guest, Jose Jr. in here as well. He has over 17 years of experience in the business development, healthcare management, and consulting. For those of you that tuned in on last week's webinar where we talked about compliance and telehealth, he also owns a mental telehealth practice. Jose, did I miss anything?
No, I mean that pretty much that's the succinct way of putting it.
Yeah. So the just a little bit of background of what we do to keep it simple for you guys. We specialize in healthcare compliance, specifically in HIPAA privacy, HIPAA security, OSHA, Medicare waste, fraud, and abuse compliance. Our goal is simple. We have developed compliance training programs for healthcare organizations, healthcare students, and business associates alike. And we're essentially here to help assist with all your compliance needs. So without further ado, let's talk about today's objectives. One, we want to discuss obviously the basics of MACRA and MIPS. We want to explore how MACRA and MIPS came about. Talk a little bit further on the implementation of MACRA and the introduction of MIPS, and look into Jose, there's a lot of acronyms behind these.
So one of the big things for me is the federal government and these politicians love their acronyms, love their nicknames for things. So it's always important for me to make sure that when we're looking at something that's coming out, is understanding what is the actual acronym mean, and then what does it do, right? Because some of it's a little bit more complex than just what it says. So it may get a little bit into the weeds, but we're going to try to keep it short. So that's why we kind of split it up into 3 areas. Today is the how did we get to MACRA and what is the whole point of MACRA. Next week would be should I go for the MIPS or the AAPM? What metrics, or should I even play at all? Because that is an option. It's not a popular one. It's not one that the federal government wants you to pick, but it is still an option. So it's really something to where we're gonna go over how to distinguish and what kind of things you need to assess when making those decisions for your practice.
Yeah, and let's dive right in. And Jose, can you provide the audience just a little bit of overview of MACRA and MIPS and sort of how they work together?
Absolutely. So when we're looking at the whole purpose of MACRA and MIPS, we're looking at dating back to 2008 with President Obama and the PPACA, which basically the federal government and the Democratic wing of politics here in the U.S. has been wanting to transformed the way healthcare is provided here in the United States for the last, God, 50, 60 years. So we're going to try to take a non-political approach to this and just say, look, these are the facts. So in the PPACA, there was a whole bunch of information. But one of the things that was starting to come out that's appropriate to our topic of conversation today is meaningful use. And meaningful use is a program that the federal government instituted to kind of get the healthcare industry to catch up to every other industry in its technology levels, because they found that by using technology, there's a lot of ease of care. There's a lot of things that could be caught for the sake of quality and for the sake of cost savings. Now, that's a lot of words to say. That was the pitch. The actual reality of it all was the federal government was wanting a way to track what kind of information was being given to the federal government. They wanted to track spending and they wanted to track outcomes. And they also wanted to catch people that they felt were defrauding the federal government on purposely or on accident. From 2008 forward, it has been, even if you're doing it on accident, you're doing it accidentally on purpose. So what meaningful use did was there was 3 phases involved with it. Great, you can go to the next piece. Sure. Meaningful use was a carrot, or yeah, let's go with the, we can go, I know meaningful use is the next slide. Sorry. That's my ADHD showing. So when we talk about the MACRA TLDR, it's going to the 2015 CHIPS Act, which took place after the PPACA from 2008. And the whole idea for MACRA was it's an evolution to build on top of what the PPACA and meaningful use were already doing. Let's track more of these metrics. Let's change the way that we're working the entire industry. Let's take a look at also how cost incentives are in place. So for example, anybody who's been in the healthcare industry for a while has heard of the SGR. They may not know exactly what the SGR was, other than if somebody mentioned SGR, it was to say, oh crap, they're going to take Medicare funding, which directly means they're going to take funding out of providers' pockets. They're never going to make the Medicare patients pay more because that's politically infeasible. So the SGR was a rate that was decided by HHS and CMS to curb Medicare spending. What they didn't take into account when the SGR was put into place in the early 2000s was that there were going to be all of these baby boomers getting into Medicare and not enough millennials, Gen Xers, and Zoomers weren't even born then, or they were just starting to get born then, to pay for these patients, these Medicare patients. So they had to find a way to curb costs. So instead of saying, hey, we're going to give you a 40% reduction, they were like, hey, we'll delay it this year. We'll delay it this year. So every time it would come up in a budget conversation, oh, no, we're just going to delay the SGR. It was up to, by 2015, if they had actually followed the rate, it would have been a 15% reduction in your Medicare fee schedule. That's some kind of haircut right there. That's, so they were like, all right, well, fee for service is killing us. We got to change the way that this is done. So let's look at quality measures. So this is where we're kind of going back to old ideas, but in new ways. If anybody remembers the capitated system of HMOs, of, hey, I don't care how often you see the patient, but I want that patient taken care of, and I want the most serious outcomes handled. Well, federal government in the 90s and private insurances figured out that when that happens, the patients were seen a lot, but the providers aren't stupid, so they would discriminate, whether consciously or subconsciously, from the patients that are healthy to the patients that are sicker. Because if you're going to pay me the same, then screw it, I'm going to take the easy ones. It's just a natural incentive. So then they went to fee for service. Well, fee for service. All right, every time I see you, I get paid. So then I want to create more visits. So now they're going back to the, okay, well, what if we set up a situation where we would incentivize the providers to handle multiple situations at the same time, be efficient, and make sure that patients, remember this MACRA is based off Medicare, is your primary care is talking to your cardiologist, which is talking to your ortho, which is talking to your pain management, which is talking to your psychiatrist. So you have more interoperability, you have more flexibility. So this is where, your bonuses are based on your quality, your resource use, the advancing care, and the clinical practice improvements. So quality, this is where, in 2015, everybody was worried about the dreaded customer service surveys. This is where, hey, we want a patient portal so the patient can have more access to care and access to information and diagnoses and medications and all of this other crap that honestly you're going to end up doing just because you didn't want the patient calling you every 20 minutes. So it's just a matter of, this is what's next. Now, we have to know what the rules of the game are if we want to win. And most of us here are working with for-profit companies. So the longer the company's around, the more time we get to get paid. So it's a win-win for us. So go ahead, Ray.
Quick question for you, Jose. So if I heard you right, MACRA replaced SGR?
MACRA replaced the SGR. It replaced meaningful use. It replaced PQRS. It replaced the what else is it? I have it down here on one of the other slides as well. So it replaced and consolidated quite a few programs that were already in place, but you'd have to go to a bunch of different places. Anybody that right now has dealt with PQRS, and then they got to go into PACOS, and then they got to go into Availity, and then they got to go and do this. It's like 6 different programs to do one thing with one provider. So the whole point of MACRA was to just streamline all this stuff, which was where high tech kind of came into play, and then the omnibus rule, and then it kind of streamlined it down even more. And then now we're deep into the MACRA realm where you're either getting paid extra, getting paid the same, or getting paid less.
Dealing with your consultant background, would you say healthcare providers responded well to that transition?
The healthcare industry at the small private practice level hates change.
Of course.
Absolutely hates change. They will fight change tooth and nail. It is extremely funny. The small private practice realm is extremely reactive. Because right now, especially, you're seeing that a lot of these providers are Medicare aged or slightly younger. They don't like EHRs to begin with, and it took them forever to get onto EHRs. And most of them were carrot and sticked with meaningful use to get onto EHRs. So now that they're on there, it took a while for us to be able to convince the providers to prescribe by EHR, to document properly so you could code properly so the practice could get paid properly. So it went from the wild, wild west of I'll document whatever and then I'll go back and change it if I need to the provider actually documenting everything as close to the time of visit as possible. Now you still have some providers that are documenting stuff from a Monday visit on a Friday, which is wild to me, but you still have those old school methods, right? Like that's just their process. Leave them alone. It's not worth the fight, So it's one of those like, where do you pick that battle, right? As an office manager, as a consultant.
No, good point. And like you said, and it makes sense. Smaller organizations have a hard time changing processes. I mean, even on the compliance side of things as well. We'll deal with practices that are doing things in house, and they're completely fine with it. Right up, I got this policy and procedure manual that I've created over these years, and it's my manual.
Absolutely. And, so right now, what we always recommend providers and small practices and medium-sized practices to do is take a look at the specialty that you're in, take a look at where that population is going. So different parts of the US have different specialties that are either booming or on the verge to boom. So here in Florida, right now we have a major mental health issue and we have a major dermatology issue. If you're a dermatologist or you're in mental health, get your butt down to Florida. It's a freaking gold mine, right? Depending on where you are, you can have a very successful seasonal business, but it just doesn't make much sense for certain things. So, like ortho right now, all over the US, you're not having a problem because Medicare age patients are there. Now, if you're looking for high Medicare volumes, which you're going to have on a healthy practice, a different percentage of a payer mix, right? So here in Florida, it's normally seen as a healthy payer mix to have something as high as 50% Medicare, where in other states, that's completely not viable.
Right.
Because of the population. Now, there may be other states and there may be other specialties or other facilities that Medicaid, working with a Medicaid program, actually makes sense. But that requires forethought, planning, government funding, so there's always processes that need to be looked at to see what's the best methodology, right? So it's take a look at your payer mix now, take a look at what you want your payer mix to be, and then fill in the dots from there to make that a straight line.
No, good points. And let's talk about let's go back to meaningful use and its role. What did it play in terms of the MACRA MIPS framework?
So meaningful use was the original carrot and the stick that the Obama administration, as I was saying, were put into play. And if everybody remembers, meaningful use, the carrot was if you're in Medicare program or you participate in Medicare, you can get up to $36,000 if you start with the meaningful use program right away. And if you're working with Medicaid, it can be $44,000. So everybody in the healthcare industry was like, hey, perfect. I like free money. I'm already taking Medicare. I'm already taking Medicaid. Fine, I'll do it. That was the carrot. The stick was, hey, starting in 2009, instead of you getting a bonus to your payout, now we're going to decrease it by 0.5%, by a whole percent. So the federal government and HHS truly enjoy using the carrot and stick of, okay, fine, if you're not going to do what I want you to do, then screw it. I'm going to start taking money from you.
It's wild.
So it's something to where even to this day, I know of several providers that never went on to EHRs. And I know other providers that are transitioning their practices out of EHRs.
Out of EHR? That's
entirely out of EHRs because they're done. They're done with dealing with the nonsense. They're done with the bureaucracy.
interesting.
They'll take the pay cut. And sometimes they're saying, screw it, I'm just not going to take Medicare.
I was going to say, I don't see that. Well, how often do you see that? I don't see too many
So there's
practices
certain, again,
transitioning from.
it goes back to certain specialties are far more insulated to the to the idea and concept of I'm just not going to take Medicare. Right? But it just, you have to take a look at what is your clientele. If I'm oncology, for example, so cancer patients, kind of doesn't make sense.
Of course.
Now, if some of the changes that they're looking at making to Medicare, where it's a 30% decrease, and there's certain limitations on having an infusion center or being able to work with biologics, then yeah, screw it. It may not be worth it to me. If I'm just an office and I'm just doing consultations, I'm just office visits for essentially. Yeah, there are absolutely some specialties that it would make sense not to work with Medicare. PT is one that honestly could thrive without Medicare. Physical therapy, occupational therapy, you can absolutely thrive, carve out a niche, and not work as hard if you don't take Medicare patients. It requires you to look at healthcare in a different way, Rather than just saying, I'm a doctor and letting the patients come to you, it requires more active marketing. It requires a concept of, hey, the customer service, customer experience has to be something positive rather than just something the patient tolerates. So it's absolutely possible. You just have to be willing to make the change.
What's that look like in the mental health industry?
So funny that you mentioned that actually. Right now we are discussing that we will probably only be taking Medicare as the sole insurance for our practice by next year, just because of the headaches that the private insurances are giving us as a mental health practice. Now, for us, the next step would be that, all right, we're done with Medicare as well, which would mean that we can absolutely do that, especially if I focus on the counseling side. So if I'm a psychologist, I'm a LMHC or an LCSW, then I can just see patients and just charge $100 a visit and be done with it. Whoever can afford my time affords my time. Whoever can't afford my time, sorry about your luck.
That's how we
And
did
you're
it.
gonna
That's
find
how we did it in the weight loss.
absolutely. I mean,
Cash pay. Cash is
it's
king.
one of those things where with certain specialties, you will find that patients will find the money to pay for it. If you are able to show that you are valuable to the patient.
That and it's a motivator for the patient as well,
Yes. You find different benefit pros and cons to cash businesses, but going back to that meaningful use conversation though, because we're on MACRA, right?
Yeah.
So when it comes to MACRA, when it comes to meaningful use, that was really one of the tools that they used to get providers to respond, and it was extremely effective. Now, providers were extremely mad as a whole when they found out that this $36,000 bonus, this $44,000 bonus, never really materialized the way that they expected, because they were expecting a check. And what they got was a percentage increase on the payout.
Yeah.
So they kind of hoodwinked the providers the same way the military hoodwinks your signing bonus. Yeah, you're going to get it, but you're going to get it with over a couple of years, and it's not exactly the way that you thought you were going to get it.
You're not just getting one flat check for everything.
Yeah, you're not getting a check to buy your kid a brand new car.
Too good to be true.
Yeah, so it is. So that really created some consternation out there. Then that was also the time period where you started seeing some value-based models come into play. The things like ACOs, accountable care organizations.
Yeah.
So ACOs, the whole concept was the federal government was going to pay you a certain amount of money to manage a certain amount of patients. They were going to basically treat you as a Medicare Advantage company. Whatever you save is your profit. If you overspend, you're SOL. So when it comes to these value-based models, you find that with our current healthcare system, people did not change how much they charged for these services. So I would go to a value-based model and I would try to charge the value-based model, my accountable care organization, the same price as I was charging a Medicare fee-for-service system. So newsflash, it's not going to work.
Right.
It's not going to work.
Right.
You have to change the business model. You have to know how much things cost.
Yeah.
You can't just base it off of one system versus the other. So this is where you started seeing that the federal government was open, willing, and active on the conversation of how do we move from this fee-for-service model so we can manage these patients for one, a much longer period of time than was originally designed. Remember, Medicare was supposed to only be around for patients for the last 3 years of their life. In the last 80 years, we have moved the life expectancy in the United States from 63, 64 to 84, 88. Now the lower age is always guys, and there's a ton of jokes as to why. We don't need to go into those. Everybody can put those jokes into the chat. I love seeing all those. But we look at that now. All of a sudden, people are staying on these Medicare models for as long as they were in their career as an adult. The federal government, the Medicare program, the Social Security program were never designed for that.
Right.
So now you have the multiple issue of I have more patients that are living longer and I don't have as much money coming in. And they're getting sicker as they get older. Because when you're 64, in 1942, 1945, you were dying from a heart attack or a stroke and it was done. Well, now it's not the first stroke that gets you, it's the fourth one.
It seems
It's
like
not the first.
something's gonna
Yeah,
have to change eventually.
absolutely. So the federal government is playing with those models, and that's where the MACRA and MIPS program comes into play after the meaningful use program comes in, where they're like, okay, well, we're going to give you a bonus if you can keep the patient out of the hospital. The PPACA, meaningful use, part of one of the metrics in meaningful use, which they pass over to MACRA, especially for hospitals, is if that patient gets readmitted, you're paying for it. So if you're going to discharge that patient, you better make sure they're good.
Make sure that you've ran every
Make sure that
possible
they're
test.
good, because if they're back in under 30 days, I don't care what it's for, it's coming out of your money.
That's wild.
So all of this data that we've been giving the federal government since 2008, now for MACRA and MIPS, all of a sudden they're weaponizing it now. They're using the data. They're figuring out, okay, well, in this area of the US, we have a propensity for these patients to be this sick and last this long, and this is the normal care. These are the codes that we're seeing. This is the frequency that they're going to the provider. I mean, the amount of data the federal government has just from 7 years of meaningful use completely influenced everything that we're doing with MACRA.
No, that's a good
if
point.
You're getting pinged for Medicare audits, which got really bad during the recession, where you would see providers going, and here in Florida, a lot of podiatrists and chiros and orthopedic surgeons, they ended up on what's called Medicare prepayment review. Well, it's because as you send things electronically, the federal government is pinging and flagging anything that stands out. Well, what happens to a nail among a sea of nails that's standing out? You're gonna get hammered.
It's a matter of time.
No, it's not even a matter of time, because it's happening instantaneously.
Right.
The federal government and these EHRs are transmitting data, and it's being compiled and assessed almost instantaneously. So one of the beautiful things about the EHR's meaningful use in MACRA is that we're getting paid faster as a practice than we ever have before. The problem is that we're giving them so much data that they're finding out what is sticking out extremely quickly.
Yeah, that's
so it's a double-edged sword. You have to know what you're dealing with.
Yeah.
So go for it. What's next?
That's something that we're going to be elaborating on. This is going to be sort of Jose, a 2 or 3 part discussion?
I think it's going to be a 3-parter.
Yeah.
Because this is all like the background. This is all the acronyms, okay, what are we looking at? Why did MACRA come into place? And then it's, okay, this is MACRA right now. And then there are certain things that we see in the future. One, because we get access to certain RFIs and RFQs from the federal government. So requests for quotes, requests for information in regards to certain incentives. And then there's the aspect of we're reading the political tea leaves as well.
Yeah.
Because there's a certain part of the U.S. that wants to currently move to a much more nationalized system. There's another part of the federal of the electorate that wants to move towards even less than what's going on now. The only thing that everybody can agree on is that healthcare in the U.S. is broken. It's just what your outlook is on what the solution is.
Good point. And this is Jose's favorite slide here. This is yeah, safe to say the MACRA and MIPS, that this brings all these acronyms into play. And
you have so many acronyms. I
I
wonder
can't keep
if
up with it.
well, no, and this is just for the one topic.
Yeah.
You know what I
This
mean?
is the
Like all of
basics.
the alphabet agencies have their own acronyms for everything. Everything's got its own acronym. Like I swear these politicians get paid money by the amount of acronyms they put in a piece of legislation. So so we got to take a look at, okay, we were talking about fee for service, we were talking about the value-based payment methods or model. You got the PQRS and PICOS and the value modifier and the meaningful use. Now I put all these up here so that way you can look them up to really dive into detail, right? So when we look at the value-based payment model, that's your capitation, that's your outcomes, so if I have, let's say I'm a chronic care management company, I have a contract with an insurance company, and they say, hey, you keep people out of the hospital, we're going to pay you X over what you normally get paid. Well, they have an incentive to keep you out of the bloody hospital.
Yeah.
Like, hey, if I'm an oncologist and I'm working with an insurance company, the more people I keep out of hospice, the better. Because then there's a profit incentive there. Now, there used to be kickback. Kickback and Stark laws are still into place, but you're going to see that based on where the federal government is going, Stark and kickback are going to have to be modified quite heavily. Because if they want for us to be able to do the things that they're asking us to do on the chronic care side, on the value added side, on the customer experience side, and they're going to pay us for it, they're going to violate kickback laws themselves. So they're going to have to change it. One of the other things that's coming down the pipe that has to do with MACRA as well is what internally we like to call the ACO version 3.0, which is basically Medicare is going to start picking out systems, hospitals, practices that are going to contract directly with Medicare. The patients are going to be attributed to them, and then they are going to basically act as the fiscal intermediary for Medicare for that small area. So let's say I own a practice, it's called Acme, and I have access to a bunch of different specialties. So then I'll go and say, hey, federal government, I can handle the patients for this area. Look at all the providers I have. Look at all the access the patients can enjoy. So then they'll say, okay, cool. Well, then if that's the case, then we'll pay you and you handle the care. So you're going to see that a lot of providers are going to end up on this same ACO kind of pick list with different companies based on the amount of patients they have, based on the outcomes they have. And you're going to see that certain providers and certain specialties are going to be popular again. Everything is going to be going back to being far more controlled by the primary care provider. So we're always recommending that if you're a specialty, capture as many of those patients as possible as a primary care patient as well, so they can be completely attributed to you.
No, good points, Jose. For the audience's benefit, what solutions would you recommend? If we have any healthcare providers in here that can implement to better navigate MACRA and MIPS?
I would say right now, if you don't know what MACRA and MIPS is and you're a provider, you have to be an employee. Or don't participate in Medicare. Because if you're going to try to navigate MACRA and MIPS and you have never heard, and this is all brand new information for you, what we went over today, then my name is Jose Delgado. Contact Ray. He'll give you my contact information because there's a lot of work we need to do. Because this is all based on billing and coding and processes and
maybe like a better word that question. What if you're speaking to maybe healthcare or residents, that are looking to own their own practice one day, and obviously, you don't learn these. I don't think residents learn these things in
they never teach business.
Yeah, they don't teach us in med school, which is crazy. Yeah, it's still crazy to me that they don't. But I think it's intentional.
It may be.
Yeah.
I would say that if you're looking to start your own business or you're looking to expand, you need to take a look at the area that you're in and the patient population you want to serve. If it makes sense, go for it. If it doesn't make sense, don't bother because it's a lot of documentation. It's a lot of tracking. It's a lot of working with the EHR. I mean, back in the day when we were dealing with meaningful use, one of the measures was that we had to submit and attest that our providers are actually sending out a certain percentage of the prescriptions electronically. Well, the problem is that the system was a live system and taking into account every single day. So I could attest the day before that we were going to attest, or I could attest in December. Yeah, we're doing it. We're reaching this number, and then all of a sudden, come the due date, all of a sudden I have no proof. It's what the system says we're doing. So we actually had to go and defend several of our clients and say, no, 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 no. At the time the office manager was attesting, the providers were meeting the meaningful use metrics. So they were not fraudulent. These were legitimate results. So what we started telling them was, you better screenshot that percentage because the
That's
EHR never stored
exactly
it.
what I was thinking. Get us take a
You have
picture.
dude, you have no idea. But then we were sitting
Any
there
sort of
trying to prove
physical
negatives. So we
evidence.
had to go and do stupid things to prove negatives to the federal government.
What's the
This is
turnaround
how
on
it
that
goes.
when you're
On
dealing
what?
just submitting that information, get a response from them?
You don't get a response. You submit it electronically and pray they don't contact you.
Oh God.
Oh, because if they contact you, something's wrong.
Sure.
You know what I mean? Like if the federal government is contacting you about what you attested to any specific year, it's
You're
because they found there's an
you're in
issue.
trouble.
Yes.
Makes
Yes.
sense. Makes sense. Well, now this was
So
did you have anything else to add, Jose? Sorry.
no. So that was, I mean, that's basically the background. Next week, we're going to dive deeper into the different
Yep.
sections.
Yep.
So if you're having problems with different sections, definitely write those questions down. Let's go over it. Let's punch it. But realistically, it's if you want to know what's going on now, you have to know how we got here, which is why we went over meaningful use really quickly, which is why we even touched on the Social Security Act real quick tangentially, because that's what started the whole mess.
No, I appreciate that, Jose. And again, for those of you that have just joined in for the first time, always had this slide up towards the end. This isn't an OSHA related topic. Obviously, we're talking about Medicare, MACRA MIPS, but just a free resource for you. If you guys haven't done your OSHA training this year, we do offer a free OSHA course. If you go to epicourses.com, you can register and take that course. You can take a lecture, a test, and once you complete the test, get your certificate as a downloadable, printable PDF document. Jose, I think we had a quiz on this not too long ago, but as far as the OSHA requirement, you have to complete the training within 10 days. And that's for new hires.
Yep.
Any new hires that you're bringing on board to the practice has to complete OSHA training within 10 days. Like I said, it's a free resource that we offer. Why not take advantage of it? And like Jose mentioned, we're here to help you in any way that we can. We do offer a multitude of different programs, from all-encompassing programs that manage all your compliance, whether that's policies, procedures, training, tasking, sort of to help streamline and keep up with these processes. Let's face it, it's tough to do these things on your own and in-house. And ultimately what it boils down to, I think, Jose, is just staying up to date is the biggest problem that I see practices are facing.
Well,
Um,
it's not just the staying up to date. It's the how can I do this
it's
without it taking up my entire life?
exactly time management, and
Yeah.
that's what we're here
How
to
do I how do I
streamline.
do this without getting overwhelmed?
Agree. And obviously, regarding the macro MIPS, I mentioned Jose is a consultant and has a lot of experience when it comes to these things. If you guys are interested in learning more, or scheduling a side conversation, We will be sending out a link. You can schedule that meeting, just quick 15-minute conversation. You can discuss your needs, and we can go from there. Other than that, we are going to open up for just a short FAQ. And if you guys have any questions regarding this presentation or anything, any questions compliance related, whether it's related to this topic or anything otherwise, please feel free to share in chat, and we'll respond. You there? I appreciate you. And is this your first webinar that you've attended? Awesome. Glad to see you on, and hope to see your attendance in the next week's webinar as well. As mentioned, we are going to be expounding upon the MACRA MIPS topic. So
Yeah, there's a lot of meat on that bone.
Yeah, there is. Hey, it's a good thing for us, right? We if we were to
I
not,
mean, it keeps
this would be a 3-hour longer conversation if
it would be so boring.
I don't think
to
I
do
don't
as a
think
3 hour, like
our I don't think
I
our
don't know if I could
attendees
do
have
it in one go.
that kind of time.
Yeah, I don't know if I could do it in one go personally. So I mean, it's perfect for my ADD.
Yeah, Liliana, I appreciate it. Vanessa, thank you. We'll give it another 30 seconds. If you guys have any questions, please throw them in the chat. Actually, if you guys have any topics that you'd like us to discuss in the near future, please feel free to share that as well. Darlene, thank you for joining. Hope to see you guys at the next webinar as well. As I mentioned, we will be sending out a registration link. It should go out tomorrow for everybody that had attended this webinar. Stay tuned. Victor, thank you so much. Hisha, are you referring to the Certified HIPAA Security Officer training? Our target deadline is going to be the end of this month to offer that online. That's our target. I don't want to give you any promises, but that's the target right now. So, until then, I'm going to keep talking about it and keep harassing all the attendees that it is a course that we will be offering soon. But it will be online, and like I said, our target is the end of this month. Hopefully in the coming weeks, maybe I'll have a better time frame for you. But as of right now, that's the target. And I'm excited that you're interested in taking the training. I took it myself. Jose is taking it. He's an instructor of the course, and I don't know, Jose. It was I wouldn't say it was easy.
If you're
But
in the industry, it's much easier. What we found
100%.
is that if you're new to the industry and you're just trying to go and get a compliance piece of paper, it's a little tricky. It's a little tricky because there's a lot there, right? You know, the learning curve is extremely high at that point. But if you're seasoned, if you're in the trenches, then it's not going to be too
bad. We still and another thing, when we did this in the in-person events, it was like a whole day, just a complete boot camp, 8-hour boot
8
camp,
hours.
8 hours, and then you get a study guide, and then you take the test the next morning. So
Yeah.
I think this is going to be a little more relaxed, from my
The
understanding.
schedule should be far more relaxed
The
for
online
this.
version is going to be a little more relaxed. Not to say that it's, like I said, if you're in healthcare, yes, you're going to have a slight advantage because you should have some sort of basic understanding of HIPAA, but you know, make sure that you're paying attention during the lectures. Obviously, when you're taking courses online, listen, I'll admit it. Sometimes I take the course. I mean, I just push it all the way through and just take the test. Right? This isn't something that you'd want to do for this.
You would have to be very well versed in HIPAA to be able to pull it off.
Yeah. Cost has not been 100% set yet, Amy, but that's a great question. if I see you on next week's webinar, I'll see if I can get a response by before then. But I'll certainly have an answer by next webinar regarding cost.
It's not going to be as, I do know that
I
it's
was
not
going to
going to be
say,
as
Jose,
expensive as in
what did we
person.
charge at the in person? Was it 1,200 for the in
Yes.
person? I believe.
Yes.
So I think it's going to be a little less than that, Amy. If
Well,
that gives you some sort of idea.
yeah, it's going to be. I from what I understand, it's going to be significantly less than that.
Yeah.
Which is unfortunate for me because I like seeing all of your faces. You know, I like interacting with everybody. This is fun for me.
Well, I mean, our conference is all about compliance and innovation, so there is some more benefits other than just the in-person course. So maybe
Hey,
some attendees
more
in
than
here,
just seeing my sparkling face, you
maybe
know.
some attendees in here would want to go to that. So obviously there's CMEs involved and all that good stuff as well. So, but we're not hosting our next in-person event, I believe, until 2025. We're taking this year off
Next
just
year,
to sort of
next year is
regroup.
the
2025 is when we're going to have our next in-person. Victor, is this in regards to topic of discussion? I believe that's what Victor had sent a chat mentioning discussing possibly cultural diversity in the future in healthcare. It's a good topic.
diversity. I mean, in what respect? I mean, there are certain things that compliance-wise we have to follow in regards to cultural diversity. So, for example, one thing that's not normally followed nearly as much and is not something that the federal government has shown an interest in prosecuting, but is always an option for them, is the fact that if I'm a practice, I have to have access to
translator.
4 of the major languages in the area for my patients, if for Medicare. So, for example, here in Florida, it's in Northeast Florida, it's English, Spanish, sign language, and Creole. I believe it or not.
Yep.
So we have to have access to interpreters for our patients. So is that something? Is that what you're referring to, or are we referring to something a little bit different?
Victor, if you can expound upon that just a little further, I think that'll help us sort of dial that in. In the meantime, for those of you that are still in here, and I'm going to be sending this out in a email post follow up. But I've mentioned this previous. We do have we did put these videos on our YouTube page. We've been meaning to do that for some time. So if you guys are interested in checking out some of our previous webinars, I'm going to post a link here in chat. Victor responded, he said, no, as an employee is for a home healthcare company.
I mean, there's nothing saying that you have to. I mean, I would say that you would want to, like I said, for the customer service side of things, because if I'm a home health, I'm doing one of two things. I'm either taking heavy Medicare or I'm not touching it at all. I don't know where in the US you are, but I would say that I would want cultural diversity so that way I can put patients with people that have similar cultural values. So that way I have the patients are far more amenable to what the staff are saying and doing, and there's more understanding. So I would say that, it's definitely something that needs to be looked at for a lot of practices. I don't know necessarily how much action needs to be taken there that isn't naturally being done on the ownership side. Now, if an owner is not leveraging people with similar cultural values as their clientele, I don't recommend it, but I'm never going to tell somebody that they have to because it's not something that's required. There are certain tax incentives involved with, for example, hiring someone that has autism or Down syndrome, but that's not a compliance issue. That's more of a tax incentive to do so.
Victor, if you want to have a side conversation about this, as I mentioned,
Yeah, absolutely.
we're gonna get you're gonna receive an email with a calendar link you can schedule, and we can sit down and discuss that further. So it looks like Victor is located in Nevada State, or Nevada State requires us to have annual in-service on cultural diversity.
Oh no.
Interesting.
You have to have a DEI training?
I didn't know that
I
was
didn't know that that was a requirement, a state
state
specific
requirement.
requirement. That's definitely something that we can help you out with. I just have to take a look and make a phone call or two and see what needs to be in that training, so that way you can um punch that in the face pretty as easily as possible.
It's actually a good, Jose, and honestly, just give me some ideas. I wonder how many states require that, and I would assume maybe.
I would take a
But I
look at the
have to
state
look into it.
houses and it'll probably tell you which ones need to do it.
I just we do offer some offshoot courses on epi for our epi compliance customers, like active shooter and stuff like that. That cultural diversity kind of sounds like it could potentially you know be a state requirement throughout. So might be something to look into.
I would be interested in seeing if that does end up happening. It makes things far more difficult than it needs to be if they force the hand of the healthcare industry, but
Right.
sometimes a little bit of coercion is not a bad thing.
Yeah, Victor, we'll certainly be in touch, and no, I appreciate the feedback there. That's awesome. And um, all
Yeah, I
right.
love
Well,
learning something new.
yeah, I know. That's one thing I've realized in healthcare. There's always something, something new to
Yeah,
learn.
yeah. If
That
not, you're doing it wrong.
I did not know, but appreciate you guys' time. I thought this was a great discussion today. I hope it brought a lot of value to you, our attendees. I believe it did. Um, Looking forward to seeing everybody on next week's webinar. As mentioned, we're going to be talking and expounding a little bit further on the MACRA MIPS and obviously the measures and metrics that come with that. Hope to see everybody there. And as mentioned, you guys will be receiving a email with the registration link to register for that event. If you guys have any questions, concerns, please feel to reach out, and we'll go from there. Jose, I
Absolutely.
appreciate your time as always, and I'll see you on the next one.
It's been fun. Yep.
Yep.
Have a good one,
Yep.
guys.
Go 49ers. Take care, Jose. Talk to you again.
Bye.